Welcome, everyone. I hope that you can hear me okay. This is Barbara Cochran. Usually you only hear me and don't see me, and that's the way it's going to be in future weeks. But I thought I'd stand up here initially this week and introduce the series. If you've attended these series before, you know how they work. This time, to try and keep everyone on track and oriented, we've prepared some introductory slides about the series and the Northwest GWEC, which is sponsoring this series. Okay, so. Oh. Okay. Just a minute, little glitch as I get the desk prepared here. Okay. So the Northwest GWEC has a mission to optimize primary care for older adults, and so you're going to see some emphasis on primary care as opposed to hospital care or emergency care. The vision for our center has been to engage families and caregivers, as well as age and dementia-friendly systems, and I'll get into that a little bit more in a minute, primary care providers and their communities to support older adult health and well-being. And our objectives include trying to help transform clinical environments to be integrated and age-friendly health systems that practice what's now being called the 4 M's. This age-friendly health system is an initiative of the Institute for Health Improvement. Many of you know about that institute, as well as the John A. Hartford Foundation. So the 4 M's are viewed as practices that should be enacted with any patient encounter. And it focuses on what matters, what's the preference for the patient, what's their goals, medications, ensuring that the medications are really needed and that they're not impacting other issues, mentation, so that we consider issues of dementia, depression, and delirium across all settings of care, and then mobility, ensuring that older adults are safe, that they are able to maintain their function as much as possible. So what you're going to hear each week is a little bit about which of the 4 M's each of the talks kind of focuses on. And I hope you'll find that fun and informative. This is just to remind you of the schedule. We're in week 1 for osteoporosis. Next week, I'll be doing a little bit about functional assessment, so you can imagine that these first 2 weeks are going to have a lot of focus on that mobility 4M. Some logistics about our Geri series. You will see Northwest GWEC faculty on site during the presentations, either me or Michael Vidiello, who is the GWEC's co-director. One of us, along with some School of Nursing video tech staff who are wonderful and are running around the room right now, will monitor the Zoom chat. So during the presentation, if you want to chat about any technical issues that you're experiencing, we'll see that. And the last 15 minutes, we'll open up the chat for questions. And I'll be conveying those questions to the speaker. And I'll also usually give you a warning to get your questions ready. Those of you who are viewing this from our sites around the Northwest region have gotten some instructions from your site coordinators. There's a profile form that just needs to be filled out once for each series. There's a sign-in and attendance form or some sort of attendance tracking that your site coordinator has talked with you about for each lecture you attend. And that will be important if you're wanting to sign up for continuing education credits. There's also an evaluation form that we would greatly appreciate your filling out. The speakers really appreciate the feedback, and we use it for planning future presentations and series. So for all these things that you should complete, check with your site coordinator. It varies depending on the site that you're at about which kind of format that you need to follow. And information about the continuing education, as I'll mention, will be coming. UW Continuing Nursing Education offers up to 15 contact hours for the full series for nurses, social workers, counselors, psychologists. They also will issue a completion certificate that you can use for other kinds of licensure issues, as well as to provide your employer. There is a $45 processing fee that's for the whole series, not for each lecture. The American Academy of Family Physicians has also approved for 15 prescribed credits for physicians. You'll be requesting these CEs at the end of the series, and details are going to follow. The recordings are also posted online at our website, nwgwec.org, about 48 hours after the live lecture. So there's information here about clicking on our activities drop down or going to the website to be able to find those lectures. And when you're there, take a look. There's over 90 plus free archive lectures from past lecture series that are incredibly useful. No CEs affiliated with those if you view them on our website, but our UW Continuing Nursing Education also offers contact hours for past series if you sign up through them. So there's a portal through UW CNE for geriatric health if you want to view past years' lecture series for continuing education credit. And now I'm very, very pleased to get to the real reason we're here, to introduce Susan Ott. Dr. Ott is a professor of medicine in the Division of Metabolism with adjunct appointments in radiology and orthopedics. She specializes in research and clinical treatments for metabolic bone disease, such as osteoporosis. She earned a bachelor's degree from Stanford, her medical degree from the University of Washington. She's board certified in both internal medicine and nephrology, and she attends at the Bone Metabolism Clinic. She's published papers about treatments for osteoporosis, bone density, bone histomorpho, I was gonna really slip through that and I didn't, histomorphometry, and renal osteodystrophy and contraception, as well as other bone disease. And she's currently doing research about effects of bisphosphonate, which is a huge consideration for osteoporosis. So thank you for agreeing to talk, and welcome. So. Okay, now we're off mute.
All right.
And I'll put this
And
here.
where do I click?
And I think she has to just click that. Is that right? So you have to move this and click right there.
Right there.
Or
Okay.
you could use these arrows.
Oh, I can use the
Oh,
arrow.
that was
Okay.
working for me. Okay.
Oh, was it?
Yeah.
Oh.
Okay. All right. Hello. Thank you for coming. And so today we're going to be talking about osteoporosis. And the disclosures, I really try to avoid most of the pharmacy companies, but I did go to a scientific advisory board meeting, but I turned down the honorarium. Okay, so osteoporosis is a very common disease. Everybody who has geriatric patients is aware of this, but it's not a simple disease. In fact, it's really very complex. The etiology is complicated and the treatment can be complicated. And hip fractures are one of the most important reasons that older patients lose their independence. So one of the first M's is what matters. That matters a lot. If you break your hip and you can't walk anymore, you're not going to be able to live independently. Now this would be what happens if we look at a little block of the bone, wash off the marrow, from the spine of a young normal person or an older osteoporotic person. And so you can see directly from these images that you have lost the strength of the bone. There's not as much bone there, and so it's easier to break. And the bone that you have is also more brittle. This leads to not only hip fractures, but spine fractures. And you could see an example of a patient here who has serious kyphosis. And do I have a pointer? Or should I just? Is there a pointer? Or do I have to use the mouse? Does it just go like that? Oh yeah, okay. So you can see the kyphosis now. It's a little bit hard to see. And that's not because the x-ray was taken wrong. It's because she really doesn't have enough bone there to really show up on the x-ray. This causes a lot of symptoms for the patient. First of all, it can be uncomfortable. The muscles are no longer attached the right way. It can decrease your vital capacity. You don't have as much room to breathe. In the more severe cases with the kyphosis, there's no place for the abdomen to go, and so the abdomen pooches out and also gives you reflux disease. That's also unsightly. And so there's a lot of psychological problem with the deformities that happen with this kyphosis. And this is one of the things we would really like to prevent. Once you've got the fractures, you can't really undo them. But there are ways that we could use to prevent hip and spine fractures, which unfortunately are not being used as widely as we think they could be. So I'm going to talk about a couple of topics, focus on them today. One is bone density and also vertebral fracture assessment. The second are the lifestyle recommendations for patients to do what they can to try to make their bones stronger. And finally, I'm going to go through osteoporosis medications. So vertebral fractures. Vertebral fractures are very important, but interestingly, they're often missed on x-rays. And you can see an example here. There we go. There's two fractures. These are moderate fractures. There have been several studies that have looked at a series of x-rays just taken as a chest x-ray without specifically getting a spine x-ray. And the investigators looked at how many of them had vertebral fractures. And then they read the reports, and only half of the radiology reports mentioned the fractures. And this, to this day, I see it all the time. They go on and on. They talk about the lungs, the heart, the lymph nodes, everything else except the bone. There's still a lack of awareness about how important these fractures are. If the radiologist actually looks and mentions them, they usually get it right. You know, if they actually say there were no fractures, most of the time they're right. But what I see over and over and over again is it's not on the radar screen. The second thing about these fractures is that if you have a vertebral compression fracture, just one, even a mild one, you're 4 times more likely to get another one than if you're the same age, the same bone density, and you don't have one. So that's the most important risk factor. If I could only get one diagnostic test, I would want to know if they'd already had a fracture, because that's 4 times more important than the bone density. It's not the way it's usually taught. So this is a very important risk factor. And in the clinical trials, if you have one fracture, you have a 1 out of 5 chance of getting another one within the next year. So they're important risk factors. And as you get 2 or 3 of them, then you get that kyphosis like we saw in the first patient. So everybody agrees that we ought to be treating people who have these fractures because our current medications are able to prevent about half of them, which is really pretty good. And that's one of the things that I'm going to be talking about. An unusual thing about these fractures is that they don't always hurt. When you look at the x-rays, you say, ouch. But when you talk to the patient, 60% of the patients don't complain of extra pain. Partly, some of them already have pain and it's just not much worse. But partly, they just don't necessarily hurt. These kind of fractures are different than the arm and leg and hip. And what I think is that about 60% of these fractures are slow. So they just bit by bit compress. And so you get an x-ray and then a year later you get another x-ray and you've gone from here to here and you've got half the height. So you can't find out if people have a fracture by asking them. you have to image them. And if they do have a fracture, they have a higher mortality and more disability. So we really need to try to find out who's got these fractures. And that leads to a new, relatively new diagnostic test that I think a lot of primary care providers should know about, and hopefully we'll start using, called the vertebral fracture assessment. It can be done on the same machines that measure your bone density, and it's basically a lateral view. And this is what it looks like. So you will, with the test, it will point out if there's any fractures there already. And the advantage to this is that, first of all, it can be done along with the DEXA. It doesn't cost as much as an X-ray, and the radiation is 1% of getting an X-ray. So there's a lot of people thinking that we ought to be including this a lot more often when we're screening people for osteoporosis. Now, this was used in the most recent NHANES survey. So NHANES is, a very large survey of the entire American population for a variety of different factors. And one was they looked at these vertebral fracture assessments. And this is interesting, only 8% of the patients who had a vertebral fracture had reported a history. Who knew that they had a fracture. And on the other hand, of the ones who said they had a fracture, only 21% actually had a fracture. So it goes both ways. So back pain is, as you all know, maybe the most common reason people go to see their healthcare provider. And many times it's just a muscle pull, but they think they've had a fracture. And on the other hand, we've got these fractures that are asymptomatic. Now, we do have the other 40% that hurt very badly. And often these are the ones that have a preceding incident. You lifted a bag of heavy groceries, you pushed your refrigerator too hard, you fell. These fractures, I think, happen suddenly, and they're very painful. But the natural history is that it hurts quite a lot for a month, a little bit for a month, a small amount. And by 3 months, most of the time, the pain from the acute fracture is better. But you can be left with some aching. So that's really what I was going to say about that, is when you have somebody that, and you're not sure if they've had a fracture and you're going to get a bone density, get the lateral view. And if they've had back pain, don't brush it off in older people. Get an image. And if there's a fracture there, then that patient really should be treated. Another thing about bone density that I want to point out is that I think you guys are pretty familiar with bone density tests, I hope, and we usually measure the hip and the spine. And a lot of times we recommend treating if the hip is got a T-score lower than -2.5. And a lot of people don't realize that T-scores are kind of specific to where you're measuring. So T-score of -2.5 at the spine does not equal a T-score of -2.5 at the arm. And what I see is somebody has been going along and getting screened, and then they get hip replacements, and so you can't measure the hip anymore. So they measure the arm. Now, in an 80-year-old woman, a T-score on an average woman at the hip is -2, and at the arm is -3. So this woman, who's an average woman and not really having any problems, gets a hip replacement. Maybe she has problems. She has not any osteoporosis problems. And so then they get an arm the next year, and it looks like she's gone, lost a lot. She's gone from -2 to -3, and she gets put on unnecessary drugs. So just be aware of that. And it's showing on this graph here that you can see this is the average woman at age 80. For the arm, she's -3, but at the hip, same woman, she's -2. And this does have some implications for how many people you define as having osteoporosis. So the dotted green lines show how many you would define as osteoporosis at the hip of -2.5. It's still quite a few, but not as many as at the arm, where you would define a lot more. And so some of the guidelines that are wanting to use the arm to define it have been influenced by the companies that want to sell their drugs. And so just keep that in mind. And we rarely actually should make treatment decisions based on the arm. One other thing about the bone density is that often people think it's better than it is, that it's more precise than it is. And so this is a study where we had some 300 people older than 65 who walked around the room, got a bone density test, walked around the room, got another one. And this is how different these tests were from each other. So you could see that, you know, about half of them were within 2%. But there's still quite a few of them who were between 4 to 6%. We saw 6% of the people were in that range. And yet I'm always seeing people who are very nervous about somebody who has lost 3%. And you have to take these measurements with a real grain of salt and not get overly concerned. I see it over and over and over again. Somebody's doing fine. They get their bone density, they have lost 3%, and their physician gets freaked out and puts them on drugs that aren't necessary, or changes a drug that they were doing very well on. If you, in your mind, think that there's a kind of area of uncertainty of about 5%, then you're not going to make those kind of errors, and you won't jump to conclusions about how terrible somebody's doing. And you have to use your clinical judgment. So if somebody lost maybe 4% and they've been doing great, I don't worry too much. I'll check it again the next year. And sometimes I will get a urine test to see if there's high turnover. We can talk about those later. And I don't worry too much. But if somebody has been doing poorly, been sick, had to be in the hospital, lost weight, had other diseases, then I'm going to be more worried, because clinically I'm more worried, and then I'm going to pay more attention to that loss and perhaps change treatment. Okay, and finally, the last thing about bone density, it's very important. We use it all the time, and it does help us decide who's at the highest risk of getting a fracture. But what matters is the fracture, not the bone density. And I'm saying you're treating the patient, not a piece of paper that came out of a machine. And so what don't they predict? Well, they don't tell you how tough the bone is. They don't tell you if the bone is brittle. They don't tell you if there's little cracks, if the structure in the microscopic structure is okay, or if it can repair damage. So all of these things don't have anything to do with how dense the bone is. So it's an important measurement, but it's not the end-all and be-all measurement. And just be aware of that. Okay, so I'm going to leave bone density. You know, I don't mean to say not to use it. We still think everybody over 65 ought to at least get a screening, and then depending on where they are, the ones that are close to osteoporosis, follow them every couple of years. The ones who are already have osteoporosis, that they would be people that you would seriously consider giving the medication to. So lifestyle is the first step in either prevention or treatment. And so yeah, this is the guy who's doing everything wrong. Okay, so obviously you don't want to drink heavily. You don't want to smoke for a lot of reasons, including the bone. Every once in a while, I'm hoping that when I tell them that smokers have a much higher risk of fractures, that might be the final piece of advice that will get them to stop smoking. Because a lot of studies show that smokers actually are listening to their doctors, and maybe if they hear it just enough times, they're going to stop. So it's worth trying. It's always worth trying. Okay, how about calcium? Is calcium a sacred cow? Well, there's been a lot of talk about calcium over the years, and it really has been changing from a lot of calcium to no calcium to in between. So we'll talk about that. Now here's some calcium recommendations from various different places that are pretty current. So the European Council says take calcium 1,000 milligrams a day, along with protein, 1 to 1.2 milligrams per kilogram per day. The United States Preventive Task Service Force says don't use calcium supplements in community-dwelling women to prevent fractures. The Institute of Medicine says the daily recommended allowance is 1,200 milligrams. And NICE, I don't know what NICE stands for, but it's the one in England, says It's recommended that a daily calcium intake of 700 to 1200 should be advised, if possible, achieved through dietary intake. So I'm going to vote for the bottom one. That's the one that I've been using with my patients. I really try to talk to them about the foods that have calcium in them. Try not to take pills unless you really just can't or won't eat the calcium-containing foods. But, you know, it's not all that hard. So, of course, if you can eat dairy, it's going to be a lot easier. So you're going to get your whole requirement if you get 2 servings of dairy and then some other servings of foods such as some of the green vegetables, tofu, almonds. And if you add the whole other category, you're going to start out with about 200. So we give them a list of calcium foods and recommend that they try to get it. And if somebody really can't, then although it hasn't been studied as well as I'd like, you could probably take an ordinary Tums, which is just the old-fashioned ones. Those are 200 milligrams of elemental calcium, and chew it right with your dinner. It has to be taken with food, and it has to be chewed, and then it'll get in as a last resort. But I don't recommend any more of these big hunks of Caltrate or Oscal. The reason is, one, that it doesn't seem to be necessary. If you put together all of the randomized trials of calcium supplements and fracture rates, it's a wash. They haven't prevented fractures. That's why the United States Preventive Task Force doesn't recommend them. And there's a question about whether taking these big blobs of calcium in a pill could cause deposition of calcium in the blood vessels, because if you measure the calcium in the blood after a supplement, it has a spike, whereas after a food, it just has a gentle hill. So this is our recommendation, and we're kind of trying to wean people off their pills and onto food. And the other important thing about food is there's other nutrients that are in these foods that are really important. So people need protein. People need all the minor things that are in vegetables. And I think you're going to be getting a nutrition lecture in 2 weeks, 3 weeks, anyway, in a few weeks, that'll go into some of this a little bit more. I already checked with her and we're on the same page. So you're going to get consistent advice here. Vitamin D, there's been a huge fad about vitamin D. It's starting to wind down, but still there. I've heard all sorts of advice, everything from 10,000 units a day to 400 units a day. It used to be that the vitamin D levels that were recommended were 200 units a day. And about 10 years ago, a lot of research has shown that's too little. Currently, for adults who are older than 70, we recommend 800, but it doesn't come in 800s, and it's just fine to take 1,000. But there's no information, or none of the data from the new current studies have shown that it helps to take any more than that for any outcome. A large study of 2,000 a day for 5 to 6 years was done, and it was funded by the NIH, and it was run through Harvard, and they had 26,000 people. So this is a really good study. And taking the 2,000 units versus the ordinary dose, no difference in the heart disease, in the fractures, in the cancer, in diabetes, in all the things that people hoped. And all the vitamin D fad, a lot of it was based on hope. And this feeling that it was really easy and safe, and you couldn't take too much because it's just a vitamin. It's not really a vitamin, it's a hormone. And it's a steroid hormone. And it has all the same mechanisms of action of cortisone and the other steroid hormones. And so we need to respect it and not overly do it. Can't remember exactly. So there was a recent study, I don't think I have a slide for the study yet, a recent study in Canada where people were randomly given 400, 4,000, and 10,000 units a day for 3 years, and they measured the bone with a sophisticated bone density machine. The 10,000 a day lost the most, then the 4,000. 400 was the best. So why is that? It's because it's a hormone that goes to the bone cells that dissolve your bone, and it activates them. So if you take too much, you're actually going to be negatively affecting the bone. And it also can give you kidney stones because it's increasing the calcium too much. And if you don't take enough, then you don't absorb calcium from your food. And so your bones are going to be too soft. So you don't want to be high or low. Where do you want to be? You want to be between 20 and 50. And there's a lot of people who say you have to be greater than 30, and that is not true. And this is probably, I think, the most convincing reason it's not true. If you go to Hawaii and you measure 24-year-old surfers, skateboarders, who are very healthy and have a lot of muscle and a lot of sun exposure, this is the levels of vitamin D you get. And you can see that half of these young, healthy surfers have a vitamin D level that's lower than 30. It's between 20 and 30. And the other half is between 30 and 50. There were 1 or 2 who got up to 60. So this should be the normal range. And this is what the Institute of Medicine, University of Washington, most of the universities, Mayo Clinic, that's what they have as their reference range. But some of you might be using a couple of labs, LabCorp and Quest, who say that the range should be 30 to 100. That's not normal. That's not the normal range. Most people aren't even there. And so all these people who are perfectly healthy between 20 and 30 keep getting told that they're too low. So what happens? So then they're given vitamin D. And then you want to check it again to see if it was, and then it didn't do much. And so they give more vitamin D, and then it goes too high, and then they check it again. How many times? $150 a test? So so it's the money that's promoting this fad to keep going. Which is, kind of discouraging to find out. We can see here one other, there's a lot of mortality studies, but they're all sort of showing the same kind of U-shaped curve, the same kind of curve we see with cortisone. You don't want to be too low, you don't want to be too high. You want to be just right, and just right is sort of right around about 30, but 20 to 40. Turns out that I discovered this by reading the New York Times, that the head of the Endocrine Society Guidelines Committee is getting paid thousands of dollars every month from LabCorp and Quest to say that the levels should be 30 to 100. So if you just keep that in mind, then maybe you're not going to try to push the vitamin D too hard on the patients. And Medicare has been paying $360 million for vitamin D testing. So we're trying to stop that fad and know where it's coming from. But you're still going to get, your patients are going to get the lab result, and it's going to have a little L on it. I say, you have to avoid that L. Okay, so that's just to wrap up. Calcium, try to get approximately 1,000 milligrams from food sources if you can. A little bit of supplement if you can't, but right with the food. Vitamin D, 1,000 a day. And I didn't mention in lifestyle exercise because that's also really very important. And I just didn't have time to go through exercise as much, but the bottom line is you want to be up. So now I am bearing weight and none of you are, okay? So weight bearing doesn't mean weight lifting. It means being on your feet. So try to walk, even a few times a day for people who can't walk. It might be intimidating to some people, especially older people, to walk for an hour at a time, but it's not so intimidating to walk for 10 minutes 4 or 5 times a day, or maybe to stand up while they're talking to somebody on the phone. You just try to get up on the feet is probably more important than any specific exercise, because all the exercise programs that you'll read, half the people drop out if it's too intimidating. And so it has to be something that you can assimilate. And once you're up a little bit, you might be getting stronger, and then you can stay up a little bit more. Okay, so now I'm going to switch gears to medicines. And I just have a little, I guess, editorial thing to say is that, but I see this all the time, even from people who everywhere, from top experts at the Mayo Clinic to medical students, is that you get the DEXA And then you decide which drug to give depending on how bad the DEXA is. And so, you know, if it's bad, they go, oh, this is really bad, we'll give, you know, denosumab or teriparatide or one of these. And oh, it's not too bad, we'll just give a little of this. And that's like, imagine that you did that with a hematocrit. So if I got a hematocrit, you don't decide how to treat that hematocrit based on how low it is. You do it based on what caused it. So, you know, you don't say, oh gosh, this hematocrit's, you know, 30, so I'm going to give iron because maybe that patient has thalassemia. Or, this is 20, I'm going to give darbopentin because maybe the patient's bleeding. Okay, what do? You find out why they have it low. You find out, were they bleeding? Are they iron deficient? Do they have hemolysis? What caused it? And then we decide how to treat it. So DEXA is like the hematocrit. It's just telling you that the bone is low. It doesn't tell you why it's low. And so our treatment should be based not on the DEXA, but on what caused it to be low in the first place. So that's what I would like everybody to start thinking about. And as years are going by, we're getting more choices in the drugs and how they work. And I think in the not too distant future, we're going to be able to tailor the drug to the reason that the hematocrits, that the bone density is low in the first place. So I'm going to show you a couple of little movies, and hopefully they're going to work. So now we imagine that we're looking under the microscope at a piece of bone. This would be one little trabecule in the middle of your bone, and you can see this would be very small, but this is where all the action is. And we call this a BMU, that means basic metabolic unit. All over your bone in millions of places, you're actually remodeling your bone. And what happens is you get a little crack, which happens if you just jump or step wrong or anything with life. And that little crack has to get dissolved. Did I knock this off? Is this still working? Okay. I jumped too hard here. So this has to get dissolved by cells we call osteoclast and filled in with osteoblasts. So the little movie shows the crack, and then it gets dissolved, and it sort of spreads out, and then it fills in again. There's the crack. So now you're dissolving it. You dissolve it kind of quickly, and then you fill it back in again, kind of slowly. In real time, the dissolving takes about 2.5 weeks. The filling back in takes about 6 months. And once it's filled in, it's not very dense. The new bone it's more like collagen, like the tips of your ears. But then it gradually gets mineral put in, and it gets like bone, like your skull. And that takes about 3 to 5 years. So we have millions of these going on all throughout our body. So I'm going to step back, and we're going to look at normal bone remodeling. This is about 1 millimeter of bone. This is actually about the size it is when we look at it under the microscope. And I'm sometimes asked, why do you make the bone green? You know, we all know bone's white. It's just because of my background in histomorphometry, where what we do is we take biopsies of the bone and then we stain them. And so we stain the bone green. So the mineral part is green. The more mineralized it is, the darker the green. And the red is just collagen matrix that's brand new. And that's what you make that collagen matrix first, and then you fill it in with mineral. So the idea here is that our bones are alive and that they're moving. So let's watch it. Speed it up. And so we're going to watch about 3 years of bone normal remodeling. So you're just always repairing the old bone. The old bone gets dissolved and the new bone fills it in. There we go. And about every 5 years or so, we have refreshed our bone. We have replaced old, brittle bone with new, stronger bone. So what happens with menopause? with menopause, when you lose estrogen, the osteoclasts live longer, so they dissolve deeper. And sometimes they dissolve from both sides of the trabecular wall. And so then you get a perforation or a hole in the bone. And that's the beginning of the bone loss that is responsible for a vast majority of osteoporosis in women and in older men. So this is a little subtle, but what you're going to watch for is getting perforations. And there's a little more activity because you're dissolving too much and you're trying to make up for it by forming more, but you don't quite make up for it. And when you there, we got a hole there. When you get the holes, then you've kind of lost the surface to form on again. So you gradually go from that first lovely lattice structure to a thinner, weaker structure, and that is what leads us to have osteoporosis. So what happens when we give back estrogen? Now we'll get the same thing with estrogen as we get with raloxifene, which is called a selective estrogen receptor modulator. They both work on the same pathway. And so now we're going to just change the osteoclasts back to what they were in a young woman or in a man who is a younger man. We don't use, actually I shouldn't say we don't use, in men, if we give testosterone, it turns into estrogen. In women, we give them estrogen directly. And it's going to be kind of subtle because these are based on actual measurements. So there's no amplification of what's going on. So it's going to just slow down the turnover. So for 6 months, you're going to see turnover, and then these little dots mean I started the medicine. And this is what it actually looks like. Okay, so we're turning over a little bit, and now we give the medicine, and it slows down. So it's a subtle effect, but we've slowed down that perforation. We've slowed down how much you're dissolving. We're actually going to gain a little bit of bone that way. And that's why estrogen and SERMs, what they're really doing, there's no perforations anymore. So we're preserving the bone and making it stronger compared to people who don't get the estrogen or the SERM. Now we can't give estrogen to the older women, but for the ones going through menopause or within 5 to 10 years of menopause, it's actually a very good method of preventing osteoporosis in the future. And raloxifene, which is a SERM, is one that we could give that at any age. And there's been studies of raloxifene all the way up into women in their late 80s. Do you want me to say the brand names too, just so people, some people just to connect. So raloxifene used to be called Evista, but it's now a generic. So you should try to use raloxifene to save a little money. Okay. Oh, I already did that one, sorry. Oops. I think we have to watch it again here because I clicked the wrong button. Okay, now what's going to be next is what happens when we treat with bisphosphonates. So as you can see the difference. So bisphosphonates also stop the osteoclasts, but instead of just turning down their half-life, they just stop them altogether. Screech. And so you stop dissolving your bone, which is a good thing, but then you can't repair any of the damage anymore. So it's going to be the same idea. You see 6 months, and then you're going to see little dots come in, which represent the bisphosphonate, and it goes to the areas of the bone that are dissolving, and you'll see the little blue dots lining the bone. Okay, here they come. And we're hardly forming any bone at all anymore. So what do we see here? Well, first of all, we're also not perforating anymore, and that's a good thing. So the bisphosphonates actually have a couple of things happening at once, and this is something that most people don't quite get. You're making the bone stronger because you're putting more mineral in and you're no longer perforating it. And so in study after study after study, there's fewer fractures. So this increase in strength lasts for about the first 5 years. But at the same time, you're accumulating these little tiny cracks and the micro damage accumulates. So at the same time as you're making it stronger, you got this negative influence. And about 5 years is when they crisscross. And with long-term use, it starts not being as good a drug. The easy answer to that one is just give it 5 years and then stop. And that was a recommendation that was considered absolute heresy when I first started saying it, right after the FIT study that I was one of the investigators. But now it has actually been recommended by major groups like the American College of Physicians, just to give it for 5 years. Denosumab is sometimes suggested as an alternate. So denosumab works in a different way. This one is Prolia, the one that's advertised on TV all the time. And if I don't get a chance to get to it, I don't recommend it unless you're an oncologist. So it's given, it blocks resorption even more than the bisphosphonates. It turns it off, absolutely. And it turns the formation off to 0. So you're really just freezing the bone. And this is what it would look like. Okay, so now give a shot. Another shot. Another shot. Now I decide to stop. So it has to wear off. Now it's worn off. You get a rebound. And what we know now is that there's little cells circulating that used to be osteoclasts. They don't die, they lie in wait and they accumulate. And as soon as the medicine wears off, they attack. And you lose bone really rapidly, which is why I don't recommend giving it. Because if you miss your dose, you get a lot of fractures. And the final one I have a movie for is Teriparatide. This one is called Forteo. And it's the same as if we used abaloparatide, which is called Timlos. They act through this similar pathway. And so we give 6 months. So this one increases the bone resorption and formation both at the same time, but formation more so. And so this, see how different this is, how very different it is than the other 2 movies. Okay, here we go. So, you know, at the baseline, average about 8% of the surface is making bone, and in a month, 20% is making new bone with this drug. So this is what we call an anabolic drug. It actually builds new bone. One of the side effects is that you become resistant to it after 1.5 years, and then it no longer is building new bone. So you only have 1.5 years or so to use this drug. So you have to use it wisely. But as time goes on, we may be able to figure out ways that we could use it a little bit more. But it's really very, very different. So you don't say to yourself, should I use teriparatide or denosumab? Say to yourself, what's the problem? Is there really, or a bisphosphonate, is there really extra resorption going on? Well, then you're going to use a bisphosphonate, or maybe, depending on how bad it is, denosumab. Maybe the bone is just not very active. Then you might want to use something anabolic to form new bone. And there's newer ones coming along that I think we have to consider. But one of the main things I wanted to say is I just want people to be aware of what the drugs that they're using are doing. And now just kind of talk about, well, when do we use the drugs? And like I say, most of the guidelines are still based on how bad the DEXA is or whether they've had a fracture. And I mean, there is some validity to that, mainly that if you don't have a fracture and your bone density is not very bad, then you probably don't really need a medicine. Then you can just do exercise and calcium and vitamin D. So these are in order of how often something happens and whether or not, or how many people would be treated. So they looked at all the data from the study of osteoporotic fractures at people who had this risk factor and how many of them had it. And the light blue is the ones that are greater than 65 and the purple is greater than 75. So that's the number of hip fractures. Not that many, but everybody agrees that if you've had a hip fracture, you should be treated. Sadly, only about 20% of them are. So there's a real gap here between a clinical situation where there's really a lot of recommendation that these people should get treated, and the real situation that we might be able to talk about a little bit later. These are the group where actually a single dose of zoledronate is going to prevent breaking your other hip in about half the women. So we really ought not to just ignore them. But that's what's happening. Spine fracture, especially well, it doesn't matter whether it's symptomatic or not, a little bit more. And we all agree that they should be treated. This is a contentious field, but everybody agrees on these top two. The next one is if the T-score is -2.5 at the hip. And I think all those people should be getting some kind of treatment as well. And that would be, as you can see, about 20% of people older than 65 and getting up to 40% of older people. Now, the rest of them are advised by various different organizations until you add on T-score of -2.5 at the spine, at the hip or the spine, osteopenia and risk factors, or all these things. If you follow the National Osteoporosis Foundation guidelines, you're going to treat 90% of women over 75 years old, which makes me say, well, if you're going to follow all the guidelines, why do any work at all? Just ask to see how old they are and hand them their drug. So I really think that if you follow the guidelines, you're going to overtreat. At the same time, I really want people to pay more attention to the ones with the fractures. And I want to call this this is what matters. Fractures are really what matter. The same pattern was seen if you looked at the data from Ann Haynes. If you followed all the guidelines, the 80-year-old women, you just treat almost everybody. So I don't want everybody to get drugs. And this is the other M, medicines, okay? So let's tailor the medicine, take it away from all those people who really don't need it and are just kind of anxious, and give it to the people who have just been in the hospital with a hip fracture, and we want to save that other hip. Okay, here's just my recommendations for when we would start medicines. Estrogen in the perimenopausal range for anybody, well, in a way, philosophically, maybe any woman who really wants to have the benefits of estrogen. But if your bone density is in the bottom 20 or 30%, you'd have even more reason, because this is a time when you can truly prevent problems instead of waiting for them. You know, it's easier to prevent the bone loss than it is to gain it once you've lost it. Raloxifene is one that you can give at any age, but you don't give it in premenopausal women, or you don't give it in women right after menopause, because it competes with estrogen. It makes them feel terrible. They'll have hot flashes, and so they don't tolerate it very well. But by the time you get to be in the 60s, it's usually hardly any side effects. The bisphosphonates I would use if your T-score at the hip is lower than 2.5, or if you've had a fragility fracture, meaning a fracture of your spine or your hip, or a non-traumatic one of your arms and legs. Calcitonin you can give that to anybody. We could give calcitonin to pregnant women and children. It's not as strong a medicine. It's considered a second choice because it hasn't prevented as many fractures as the other drugs in the clinical trials. But sometimes if nothing else works, or if the patient is just really scared of everything else, it's still a choice. Teriparatide I would use with severe disease, and it's age independent. Well, we wouldn't use it in children, but in geriatric people, there's no real age limit to that one. Denosumab, I'm currently recommending it only in people with cancer. because of the problems of stopping it. And romosozumab is brand new. It's so very new that I'm saying it has to be lower than the T of -4 before using that one. But in the future, I think it has a lot of promise. This is the newest anabolic drug where you're actually forming new bone and you're blocking the resorption at the same time. I haven't had time to make the little movie for Romo yet. But it's even better than teriparatide, because teriparatide, you know, remember, you increase resorption as well as formation. Here, you decrease resorption as well as increase formation. So it's the ideal drug, but again, it only works for about a year. But maybe it works for a year and then you hold them over and then it might become, you might become sensitive to it again so that you could use it another year, but that's very uncertain. At this point, studies are still going on. And I'm saying this, maybe you're thinking of something. For every medicine you start, have a plan for the duration and for the follow-up. And this is really critical for the injectables. If you inject zoledronic acid, that would be Zometa or Reclast, you could do one injection and really help a lot. You could do another one. It lasts at least 2 years. And a lot of times that's all you really need for your very older patient. It can last up to 5 years, or you could give one more. And this one, it doesn't, when it wears off, it's very nice gradual wear off. It doesn't cause any problems. Most of the other ones, raloxifene also, you could start and stop at will. But the newer ones, the raloxifene, I'm sorry, the denosumab, you get a rapid loss when you stop. Estrogen, you will just kind of go through a little bit of menopause loss when you stop. And teriparatide, you lose everything if you don't follow it up with an anti-resorptive drug. So you don't start somebody on that drug unless you know they're going to come back and you know they're going to get the follow-up. And we're not sure yet about romosozumab. So I just threw a couple little things here about estrogen. This is the European guideline. Maybe not quite so much for geriatric people as for doctors and nurses and middle-aged women, but the Europeans are starting to say, yeah, that is a good recommendation. And I think it's a good idea for many women, but you do have to be careful. A couple of things, though, I hear all the time it causes breast cancer. The studies show it's the Provera that caused the breast cancer and not so much the estrogen. And in long-term use, there's a little bit more estrogen-related death from breast cancer that's balanced by less death from colon cancer. So they're both awful. So it's an even wash. So I've heard, I cannot tell you countless times about how estrogen causes breast cancer. And I've hardly ever heard anybody say, I want to take estrogen because it reduces colon cancer. And those are two equally true things. And there's a bias against estrogen in our culture. So I'm going to skip through that right now. But I did just want to show you that in women between 40 and 60 in a randomized clinical trial, where they were randomized to placebo, alendronate, or estrogen, you can see that it was significantly better on estrogen. So it's not true that alendronate is a stronger medicine. And I don't have time to go through this. It's the same message. It's just 4 other studies that show the same thing. And a study that shows from the study of osteoporotic fractures that back before Women's Health Initiative, it was very common for women to take estrogen their whole life. And the ones who did, that's the red line, have fewer fractures than the ones who didn't. And that actually has been shown in several studies. So maybe we should rethink a little bit of our biases against estrogen. Here's raloxifene. I think I've already mentioned this. The thing about raloxifene is also that it reduces breast cancer quite a lot. So after 8 years, the placebo had 4 cases per 1,000, and raloxifene only 1.4. So if you have a woman who has a risk of breast cancer, this is often a really nice match. And I think I'm going to just, this is in your handout. These are just some of the pros and cons about raloxifene. So I'm going to skip through this. just mention a couple things about alendronate. In the alendronate study, this was the FIT study. When they first did the study, in 4,000 women who didn't already have a vertebral fracture, the incidence of clinical fractures was not significant. The value was 0.86, and it crossed the line. So the design of the study was to, just look at it this way, but they did a post hoc analysis according to the DEXA. And when they did that, they saw that the bone density really made a difference. So this is where the 2.5 comes from. So the ones whose hip was lower than 2.5 had a very significant reduction in clinical fractures. The ones whose bone density was greater than 2 had more fractures on alendronate than they did on placebo. And the ones in between 2 and 2.5, it was completely neutral. So I look at this data and I say we shouldn't be treating people who have osteopenia with bisphosphonates unless they've had a compression fracture or a hip fracture. And one other little thing for the epidemiologists in the crowd, in the paper, they drew the line at a place that we're not used to looking at it so that it would appear that it was more effective than it really was. And that has bugged me to this day that they did that. Just the subtle ways that drug companies can advertise at you. Zoledronic acid, very effective. This was a study of people who'd had a hip fracture already. So this is really core to the geriatric populations. And you see this nice reduction in any clinical fracture in the 36 months after getting some zoledronic acid. And it has very few side effects. So I think we ought to be using it a little bit more often, because for anybody who's demented, can't remember their drugs, has any GERD, you get one infusion of this, and then you're kind of safe. I mean, you have done some real good, and it's going to last for several years. So I think we should be thinking about it a little bit more. And one study in New Zealand, I'm putting this up just because I hear it quoted at me a little bit wrong, but the title is that they reduce fractures in patients with osteopenia. But when you looked more carefully at the methods, a good deal of these women actually had osteoporosis. And the way they define it is, if you have osteopenia in one place, we're going to call it osteopenia, even if you had osteoporosis in the other hip. So it was a little bit of a fishy study. And the fractures that they were preventing were often just kind of minor fractures of the arm. It didn't prevent hip fracture. So I'm going to stick with recommending it for people who've either had a fracture or have an actual osteoporosis. And this is another myth I see all the time, so I'm going to say it, that how long do we keep them on it? I'm saying 5 years, based a lot on this study. So this was a study of women who had taken alendronate for 5 years, and they got randomized into staying on it, which is the red and the blue line, and the black line, or a placebo, which is the green line. And this is the clinical fracture incidence. This is the FDA report, which is a little different than some of the papers that were published by Merck. And if you look at the clinical fractures, you don't need to be a statistician. See, there's no difference. So you're gonna get the same number of fractures if you take it as if you take a placebo once you've had it for 5 years. So to me, that's the strongest reason to stop it after 5 years. But then they said, well, what about the ones who really had osteoporosis? Maybe they're different. So they looked just at that group whose T-score was -2.5. And there you have it. It's misquoted over and over and over again, and even in papers that are still in press, that if you have a high risk, you should stay on a bisphosphonate for 10 years. But that's not what it showed. The ones at the high risk had exactly the same number of fractures, whether or not they took a placebo. So I just don't know. It's just wrong, and it's misquoted all the time. And I really don't think we should keep people on this drug for a prolonged time. And I just say this, fossil bones have high bone density, and fossil bones have fractures like this. So this is a fossil log, not a fossil bone. But you see the way the wood broke? That sharp, brittle, that's brittle. And that looks just like the atypical fractures we see with bisphosphonates. And this is a atypical fracture with bisphosphonate. So that sharp, right here, that sharp, brittle thing. And they start out with a pain. They get a little bump here, and then it splits right there. And this is what we see about 1 in 1,000 women who've taken these drugs for more than 8 years. So that's not rare. It's not common, but it's enough that I've got a good 60 of them in my clinic. And this is the incidence of the atypical ones. You could just see how it goes up with time. And that's going back to what I said, that when we first give it, the drug is really making your bone stronger. But then if you stay on it, your bone gets more brittle. So you could avoid a lot of this by giving it for 5 years, save the fractures, and then stop and prevent the atypical ones. And you have to reassure the patients because they've all read about these fractures. So they don't want to take it. And I say, don't worry for the first few years, really low risk. And this was actually a recent study. It's not even published yet. And so I couldn't show you all the data. I had to just do a little sketch of it. But they actually measured the strength of biopsies of women who'd taken these drugs from 1 to 17 years. So it's a 17-year span. The strength went up, and then at 5 years it turned around, and then after 7 years, down it went. Whereas the density of cracks just kept coming up, which is kind of what I was saying with the little movie when you got the little cracks. And that's actually what they saw when they did the study, what I had actually predicted in my cartoon about 10 years earlier. Okay, these are the ones that should only be used in severe cases. I would say for primary care audiences, I would probably not recommend them unless you just decided you really wanted to, get involved and learn all about the ins and outs of it. And I think I've said this several times, that denosumab is worrisome because it completely stops bone formation. You might run into the same problems. You get atypical fractures in osteonecrosis of the jaw just as much with that as you do with bisphosphonate. So you're not getting yourself into a better situation with that. But we got this other new problem that we didn't ever see with the bisphosphonates, which is what happens when you stop. And also what happens when you have chronic kidney disease. I hear this a lot. It's not metabolized by the kidney, so we could use it in the kidney patients. I say, well, that's not a reason for using the drug because it's not metabolized. You want to know, does it work? Is it safe? And the answer is, we don't know and no. Serious hypocalcemia. I'm talking about seizures, laryngospasm, tetany, having to be in the ICU for a couple of weeks getting IV calcium drips because of giving denosumab when you have kidney disease. It's just not a safe drug. And nobody's shown that it really helps, but we don't know what it does to vascular calcifications, but there are case reports of rapid increase in vascular calcifications because they have to give so much calcium to try to prevent the hypocalcemia, and then it goes in the blood vessels. And that's what kills these patients. That's another what's matter, is heart failure. So don't use it in the kidney patients. And then what happens when you stop? One study, they gained 12% over 10 years. This was the Vanguard study, so they'd been on it for 10 years, and they decided they would stop because they gained 12%. In 6 months, they lost 13%. And while you're losing it that rapidly, this is the kind of thing you get. So this would be before and after skipping 1 dose of denosumab. Before, no fractures. After, I think there were 6. This was one of my patients, but I've also seen it published. There's a couple. Do I have another one? Yeah, here's another one that I think is from a paper. We're seeing the same thing, before and after. It's a rapid loss. It's getting reported more often now. And there's not enough people aware of it. So I want everybody to be aware of that this could happen. So what could we do? Well, if you decide to stop it, you could try to give a bisphosphonate. But even when you give bisphosphonate, they're going to have a loss of about 5%. But if you don't give a bisphosphonate, it's going to be even worse. So, you know, you're really in this trap when you start this drug. So the best thing is not to start it in the first place. And I'm going to skip through teriparatide because I think it's about time for the questions. So this is just, if you're interested in some of the contraindications for using these anabolics, some of the adverse effects, and the fact that you have to follow it with an anti-resorptive or you lose what you gained. You don't have that rapid loss like you did with denosumab, but nevertheless, you lose. And I'm going to skip those and end here with, yeah, my little, we think of the bone like that. And do we have any questions? Oh, great.
Myself. Okay. So I think you covered the bears repeating. At what age do you recommend a bone density test be initiated?
Yeah. So the recommendations.
Oh, and I'm
yeah.
sorry, you should. I think because they're not picking up my asking the question. Is that right? The recording is not.
Oh, okay. So the question is, what age would we get bone density testing? And for somebody who doesn't have any particular problems, I would say 65 for a woman, 70 for a man. And if there are other diseases that would predispose you, and you know, many chronic diseases or steroid use, then you could certainly get it earlier. Anybody on steroids, that's going to be on steroids for a while. I think no matter how old you are, you want to know. But for somebody who's just kind of for screening, those would be the ages that we recommend. And I will say editorially that personally, I think that if a woman's going through menopause, she's going to be about 50, and she's trying to decide about estrogen, and she's not sure. And if she knew that her bone density was in the bottom 20, 30%, she would want to go on it, then it makes sense to check it then. And that actually is what's done a lot. So I think that's a very reasonable approach. It's not yet met the dogma, okay? But it would depend on what you're going to do, yeah.
It does pick up my asking the questions. It doesn't pick up the people in the room. So you don't have to repeat if I'm asking.
Okay.
Are you treating with pain medications at all and osteoporosis medications based on T-score?
Well, if somebody has pain after an acute fracture, yes, you would treat it with any, you know, as you would with any other kind of pain. There's a little bit of data that giving calcitonin right after a fracture can allow you to use less other pain medicines, and it's very safe. So giving calcitonin for a couple of months is always a safe idea. And then treating pain is non-specific. There's no specific treatment. Sometimes we're asked, should we do kyphoplasty? And there's still a lot of debate about that, because when you look at the randomized studies, after a couple of months, the people who got kyphoplasty are just in the same situation as someone who didn't. It might temporarily help the pain a little bit better, but in the end, they're the same. So maybe it isn't worth all the risk. But otherwise, whatever pain medicine, you have to be careful with all the pain medicines, and that's kind of getting beyond my expertise.
Okay, and let's see. Do the bone strengthening meds still impact dental problems?
The bisphosphonates and denosumab can, first of all, if you get it for a long time or a high dose, you can get a problem called osteonecrosis of the jaw, which happens if you have to have a tooth extracted or a surgery on your jaw. It's still unusual. The ones that we really see that in are the cancer patients who are getting 10 times the dose that we recommend for osteoporosis. So it's a dose-related thing. And I really think a lot of people need to get reassured. You need to, if you don't take these really high doses, your chance of dental problems along the lines of 1 in 10,000 people. So very low risk. If you want to get braces or orthodontic work, braces you have to push the teeth through the bone, and if the bone's getting harder, they don't push as well. Okay.
And here's an interesting question. Could you address the cost effectiveness of a few of the more common treatments for osteoporosis?
Well, the bisphosphonates are the cheapest by far now. So in many people, that's still going to be our first choice. The newer ones, if you really have serious bone disease and you're at high risk of getting hip fracture is costing about $40,000 right now. So most of the medicines are going to end up being cost effective if you have a high risk. But if you have a really low risk, then you're going to be spending a little bit too much on them. And as you know, these things change though. As the drugs lose their patents and things in their price comes down, and it's a constant change in the cost effectiveness.
What medication do you recommend to take when the patient stops Prolia?
So what we recommend currently, and this is changing because the data is still very new, is you wait about 8 months after the last shot, and then you give zoledronic acid. If you give it too soon, the zoledronic acid can't stick to the bone, and so it doesn't work very well. And if you wait too long, then you get this you're starting on the rapid loss. So it's an area where we're not sure yet, but sometimes, I mean, it doesn't matter if you're not sure, you got this person in front of you. That's what I'm currently recommending. And it's subject to change.
Any questions here in the room?
Yeah. Oh, you first and then you.
So I have a question about the remodeling.
Yeah.
So I know it has a different mechanism of action than the denosumab, but does it have the same effect of rebound loss?
No.
Okay.
Oh, sorry. So the question was about romosozumab, which is the newest drug that was just approved this year. Does it have the same rebound? What will happen is that you will see some loss when you stop it, and so it's recommended that you will follow it with an anti-resorptive, either a bisphosphonate or a raloxifene, and that's kind of similar to teriparatide, that we would follow it. So it's not that rapid loss, but it's still a loss. You know, it's just kind of a shame to lose what you've gained. So it's a two-part thing. 1 year of Romo, 1 year of either alendronate or raloxifene, and then we're not quite sure. Yeah?
Do collagen and gluten-free do anything? Are those recommended?
Well, collagen is like a protein, but you know what'll happen? It's not worth the cost, because you take collagen and it goes to your stomach and it breaks down into amino acids. So the same thing happens if you eat an egg or a piece of cheese or a piece of chicken. So it's just not worth the money. But I mean, it is a protein, I guess. And I'm not quite familiar with move-free. So, that one. Well, that's a rheumatology question. Yeah, glucosamine is a rheumatology question for arthritis. And I know I've talked to the rheumatologist that works next door to me, and he thinks it's very safe and worth a try. You have to take a fair amount, like 3 times a day, and it's mild, but it's so safe that it's definitely worth the try, and it attenuates the pain from arthritis. And I know there have been a couple of randomized trials that are not dramatic, but sometimes, since all the other ones can cause some problems, it's definitely worth a try. Yeah?
Are there any other non-pharmacological recommendations to prevent osteoporosis besides just getting that calcium?
So non-pharmacological would be, the nutritional ones and the exercise programs. I might say, I didn't really talk about exercise, but a couple other little points about that is that some of the doctors here at the university have been very interested in what kind of exercises make your hips, muscles around here, stronger and maybe a little more flexible, and maybe it can prevent falls, which indirectly prevents fractures. And when they did all these studies of this rep like this rep like that, turned out it was Tai Chi. So the motions that were the most effective were the ones that the Chinese discovered however many thousand years ago. So, and now there have been a couple of studies of Tai Chi helping prevent falls, and if you did enough people and prevented falls, then you would prevent fractures, because most fractures did have a fall first. So And a lot of my patients, I say, recommend it. And often older patients are a little bit socially isolated too. So if there is going to be a group doing it together, first of all, it's more fun to exercise and you're going to be more likely to keep doing it. So we're pretty much advocates of Tai Chi classes. And I also have, we send some of our patients with kyphosis or a risk of it to our physical therapists who tell them how to take care of their back. There's ways to lift and ways not to lift. There's exercise. You don't want to do sit-ups. You want to do extension ones. And then for the older people who, you know, you'll see somewhere they're lying down the floor and coming on. My 80-year-olds can't do that, but they can sit in a chair with a rubber and go like this a few times. You know, that's a back extension exercise, standing on a wall and trying to pretend you're pushing yourself into it. These are gentle ones that can help with their posture and strengthen the muscles. And it's hard to prove that's preventing fractures, but we think it might. Okay? Yeah?
Thank you for your wisdom. How, since this is such an evolving issue for older adults, how is this being disseminated? Obviously, this is one method, and it looks like there's contradiction with the expert organization.
It is.
So,
Yeah.
do you have recommendations on
Well, there's, people are wondering, yeah, thank you. How do we disseminate the newer, ongoing, evolving knowledge about osteoporosis? And what do we do about the fact that the different organizations are basically giving different advice? So partly that's always going to happen. I think one of the things we need to do is be aware of where the recommendations are coming from. I hate to be too much of a cynic, but there's a line from Hamilton: follow the money and see where it goes. And if the recommendations are coming from the drug companies or the labs, we have to look at them with a lot of skepticism. How do we disseminate what's the more accurate information? There's been an organization, called American Society of Bone and Mineral Research that's trying, they had a stakeholders meeting and what they did is they had a group of people with different viewpoints, found out what everybody agreed on. So what we all agreed on is spine fracture and hip fracture get treated, and then get that message and at least get started with that in as many ways as you can with educational programs, news people, everything else. And they're kind of working on that. There's an organization trying to get publicity out to treat the ones where we all agree. And there's always going to be some disagreement, but we can make a real step forward by treating the people who really need it. And some of what we need to do is allay the fears. People are, you don't have to say too much about the jaw problems or the leg. Those spread like wildfire, and then it's a negative problem because then people are afraid to take it, even when you could avoid it if you only take it for a few years. So trying to get a somewhat nuanced message in this day and age is hard because people want a bullet. Do this, and not a nuance, do this and then do this and then, But we could still work on it, So yeah, a web page. I have a web page. I don't know how many people actually read it. ASBMR does it. The NIH has information pages. Mayo Clinic is usually pretty much on board. So continuing with that, and maybe things like this and what Barbara's doing will help.
A question has come across about anything that you want to say about vitamin D dosing in northern climates. We have quite a lot of people from Alaska.
Right. The dose for the recommendation from the Institute of Medicine took that into account. So the dosing recommendations of 800 to 1,000 would be if you don't get any sun. So actually, and in Seattle, okay, the sun has to be 45 degrees before it will convert vitamin D in your skin. So if you go outside at noon today, if there were sun, and you look at your angle, your shadow is going to be way taller than you. That means that you could be naked in the sun and you're not going to make any vitamin D. But if you did the same thing down in Phoenix, then you would. So you could use less vitamin D. But the other caveat to that is that as your skin gets older, it doesn't work as well. So they have done studies where they shine the ultraviolet light on a young person and an old person, same dosage of radiation, solar radiation. The vitamin D levels went up a lot more in the young people. So maybe for the really geriatric population in the late 70s, we recommend they take 1,000 units no matter where they live. Okay. For younger people, if you live in the South, you don't need it. But if you live in Seattle, you could probably get by without it during June through August. Okay.
And you have some thoughts about how often we should obtain vitamin D and calcium levels, and maybe at what point to increase supplementation to higher doses?
Well, actually, they have done a study in a large number of women, and they gave them 800 units a day. These were older women. 97% of them were normal at that, then they measured it and they went up. So unless you have an intestinal disease or you're taking a drug that works on the liver to inhibit metabolism, you don't really need to check it. You just make sure that they take it. And so the recommendation is you don't need to check the vitamin D levels. If they have intestinal disease, then they're in another category, okay? Or if they have chronic liver disease.
Okay. Do you have recommendations about how long after a fracture would you consider calcitonin use for pain?
There's no definite thing. I would say 3 months, because typically that's when it's going to be better. I might say something. Vertebral fracture pain, we know this course usually happens a month that's bad, a month that's medium, and a month that's not too bad, and then not. Maybe some aching. If the pattern is different than that, then you have to get a little worried. So a couple of things could have happened. They could have had a second fracture, a lot of pain, and it's still there, and it's still really bad, and it's been 3 or 4 months. That's not supposed to happen. So then check them out. Or myeloma. I've seen this pattern. That's a sign of myeloma. It hurts more. It doesn't get better. So then be sure that you do all the tests for the, M proteins and the free light chain ratio.
So we had a request, if you could give us your website that you're mentioning.
It's a kind of a long address. So
You want to send it to me and I'll send it out.
You can send it out the easy way. I mean, if you just say Susan Ott, pretty soon down, it'll say osteoporosis and bone physiology. Okay. And so that's the fast way to get there. The other one is some great big HTTP with Washington in it. Okay.
Okay, we're coming to a close here, but a question about a 70-year-old female who falls from a stepladder, suffering a compression fracture. One would anticipate that she's at risk for future vertebral fractures in her thoracic spine?
You'd be worried about it, yes. There's always a little bit of clinical judgment involved in whether it was just the trauma. But, if she's at the top of the ladder, I maybe wouldn't be so sure, but if she was at the bottom of the ladder, I would want to treat her. We just had that discussion in my clinic just the other day. So you use your judgment, and if you think it wasn't really all that bad a fall, and I tell my people, think about the Olympics. Think about those ice skaters. Oh man, they don't break their bones, okay? So if it would have caused an Olympic athlete or somebody really healthy to break their bone, then for sure that's trauma.
Do you have time for about 5 more minutes?
Oh, sure.
A bunch of questions. Okay, so one is just asking, is there a difference between D3 and other D vitamins?
A little bit. So vitamin D3 is the kind made in animals. Vitamin D2 is the kind made in plants. The chemical word is cholecalciferol or ergocalciferol. And although they activate the receptors the same way, the vitamin D3 lasts in the system longer. And so it's pretty much shifted to that's the one that we recommend. Although the vitamin D2 works nearly as well. We've all kind of switched over to D3. I have a few very strict vegans who we give the ergocalciferol to because of their velocity.
Well, related to that then would be, what are your thoughts on recommending foods high in estrogens, such as soy, flax, etc., for menopausal women?
Yeah, that's been studied. Actually, I was on the Data Safety Monitoring Committee for two different studies of some of the soy products, soy isoflavones. There was a lot of hope, but in the end, it didn't do anything for the bone density, which was their endpoint. This was in women going through menopause, so we were focusing on the density instead of the fracture rates. But it really just didn't help, whereas estrogen has been studied where it helps a lot. Okay.
And I have one more question. What if a patient started and stopped Fosamax over 5 years and still has osteoporosis? Is treatment still indicated?
Yeah, so it depends on how bad it is and what's going on. So a lot of times if they've had it for 5 years, they're still going to have osteoporosis. That one slide I showed, those were women with osteoporosis, and during the next 5 years, the fracture rate was the same with or without further drug. Now, could we make it even better than that by giving teriparatide? Maybe. So just for maybe practical purposes until there's more data, I'm saying if your T-score is down to -3.5, really down there, then what I'm going to want to do is put them on teriparatide, or now I'm thinking about Romo. Right now I'm only using -4, but I think pretty soon we're going to feel more comfortable with it and move it up to -3. So if you're down in that range, but if you're sort of in the 2.5-ish range, I think you could just stop for 5 years, and then we're really not sure about what to do. That's where there isn't much data anymore, so you just have to use some judgment. Sometimes I just keep following them. Sometimes I put them on raloxifene. Sometimes I put them back on a little bit of alendronate. What I do, I didn't have time to go through this. There is a test, a little controversial whether to use it or not, but I really like it. And they're called the collagen crosslinks. If you're dissolving bone, then the collagen breaks down, and we can measure that. And one test is called CTX, one is NTX. They give you the same idea. The higher the level, the more you're resorbing bone. So I find this helpful when there's no data. I say, I get the NTX, I get it all the time in this situation. And if it's high, then I'm going to I'll start another medicine, because that means they're dissolving their bone. If it's not high, then I just follow them. And to me, that makes a lot of sense physiologically. And there are several other people who are colleagues of mine who agree with that approach, and there's others who don't, But what I've noticed is it's changing. So the people who want to use these markers, there's more and more of them now. And they're real easy to get, especially the NTX. You can just get a urine sample. Okay?
Okay, well, Doctor, I'm going to echo some of the chats that have come through that say thank you for a wonderful presentation.
Oh, that's nice to know. Thank you for
Great.
listening. Oh, thank you. Okay, are we offline? The movies
Had no sense of that.
the movies show that it's alive.
Yeah.
They're not pillars they're not legs on the table.
Right.